We have a great plenary session for you. We have 3 speakers. The first talk is on the global aspects of cancer staging. It will be introduced by Lisbeth van Ecken, followed by Dr. Lynn Pinberthy from the National Cancer Institute, talking about a changing paradigm for cancer surveillance. And then finally, Dr. Joanne Aitken will talk about the Australian Cancer Atlas development and interpretation. And let's get started. Lisbeth, please introduce the first speaker.
Good morning to all of you. I'm always a bit embarrassed because you Americans seem so natural and so easy talking to each other and making jokes. Thank you. Okay, it is my privilege to introduce Professor Jim Brierley. He is Professor of Radiation Oncology at the University of Toronto, Princess Margaret Cancer Centre. He obtained his medical degree from Westminster Medical School, the University of London, but he changed. After obtaining his FRCR in the UK, he went to Princess Margaret Hospital, Toronto, where he stayed. He is definitely interested, it's his special interest, to define the role of radiation in the management of thyroid and gastrointestinal malignancies. As you all probably know, he's greatly involved in cancer staging, but also in cancer surveillance, not only from the side of the clinicians, but also the cancer surveillance, which is a very nice combination. He is the stage lead for the Canadian Partnership Against Cancer. He is also co-chair with Mary Gospodarevic of the UICC TNM Prognostic Factors score group, and so also a bit my boss, and co-editor of the UICC 8th edition TNM classification of malignant tumors, and he's also chair of the AGCC Education and Promotions Committee and a member of the AGCC Executive. Jim, your name is very well known in the world, but we have the privilege here and the honor to have you here with us, not virtual, but really physically here. So I would say the stage is yours.
Thank you, Elizabeth, for that very kind introduction, and thank you very much for the organizers for inviting me, and I'll thank Lynn afterwards if she doesn't heckle me during the talk. So I'm here, although Elizabeth told you about my involvement with both UICC and AJCC, a lot of what I'm going to say, particularly towards the end, is sort of my own personal view and doesn't necessarily reflect the current opinions of UICC or AJCC. As you all know, when we come to cancer and treatment or collecting information about cancer, we need to know several things. First of all, where and what is it? And that's classified usually with the ICDO. And then also need to know how bad is it? And that's usually classified with the WHO Blue Books, looking not just at the pathology, but also the molecular classification of prognostic factors as well that may be of importance. And when it comes to how much there is of it, then that's classified with TNM using AJCC or UICC. And as you know, the 8th edition came out in 2016, I think. And the TNM was first devised by Pierre Denoir, a surgical oncologist. I'm not sure if they had the term surgical oncologist in the 1940s in Paris, but that's essentially what he was. But even when he developed TNM, he acknowledged that anatomical extent of disease was just one important prognostic factor, not the only prognostic factor when it came to determining survival in patients with cancer. And there are many other prognostic factors. We can divide those by tumor-related, but they're also, which is what's in the WHO Blue Books, histology and molecular prognostic factors, for instance. but also many non-tumor related factors such as age, performance status, social determinants of health, quality of care, genomic factors, for instance, of the patient themselves, not just the tumor, can affect the prognosis. The UICC has actually been involved with prognostic factors for some time, actually changed the name of the committee from the TNM committee to the TNM and Prognostic Factors committee some years ago. And in fact, its first book on prognostic factors was published in 1995. And the UICC have a way of classifying prognostic factors into those that are essential for treatment decision-making, additional, new and promising, and also divide them into those that are tumor-related, histology, obviously, extent of disease, host-related, age, performance status, and also the environment, which includes social determinant of health, but quality of care and things like that as well. And it's surprising, some of us, we think that, some prognostic factors are universal, such as extent of disease, such as grade. But in fact, although grade is very important as a prognostic factor in breast cancer, it's less important in colorectal cancer. And grade is not really that significant a factor when it comes to prognosis. But other prognostic factors are important, such as MSI high status, so patients often related to Lynch syndrome, MSI high, colorectal cancer, often have large tumors, but the prognosis tends to be better, and also it also reflects the treatment. They tend to respond well to checkpoint inhibitors. So there are a variety of different prognostic factors that can have different effects. So say MSI high, you may have a large tumor, but the overall prognosis may be good. But biomarkers in general are getting increasingly important. This admittedly is an old slide related to an editorial in Nature in 2011 where it discussed that there were 150,000 papers documenting molecular biomarkers, but only about 100 have actually been adopted into clinical use. And in fact, the number of prognostic factors molecular factors that are being used is actually falling. This is a slide from Caroline Compton showing that over time, there's been a reduction in the number of molecular prognostic factors approved for use by the FDA. This is partly because of inconsistency between laboratories, between papers, a variety of different factors. So there are obviously still some things that are undoubtedly important prognostic factors, such as receptor status in breast cancer, but there are more and more being published that may have no great importance. But other things are important, like quality of care. This is taken from one of my colleagues, Dr. Brian O'Sullivan, who's involved with international research in radiation, and all radiation plans were assessed centrally. And from patients who had to have replanning, and there was major deviations, when they looked retrospectively afterwards, patients who had major deviations had a poorer survival. So the quality of radiation is an important prognostic factor. So the quality of treatment, not surprisingly, is an important prognostic factor. So although we have all these prognostic factors and of increasing importance and variety, anatomical extent of disease is still a robust classification. It's universally available, it's globally available, and in many tumor sites, it's still the most important prognostic factor once you get beyond age and performance status and things like that. So it still is very valid and important, although in other sites, some sites such as breast cancer, there are other important prognostic factors that we'll come on to, but in many sites such as head and neck, it's still the most dominant prognostic factor. And we all know why we want to stage patients clinically to determine prognosis and treatment, but also to facilitate research and to facilitate cancer control and surveillance. But and there's always this overriding sort of conflict between the needs of the different constituencies, the physician and patient interaction, who want to use the most up-to-date and appropriate factors to determine patients' prognosis and guide treatment, and also the surveillance community, who wants to have as much information available globally and be stable as much as possible over time. So these two sort of conflict. So there's always this difficulty that needs to be resolved, particularly when you're thinking of new additions and how to resolve these differences. This is probably an example of the the most globally relevant way of looking at stage and the use of stage data from the benchmarking project. And this is one of the analyses looking at breast cancer survival by stage. Obviously, if you don't have stage data, you can't do this. So you need to have population-based stage data. And this showed that, unfortunately, in the UK, the outcome of stage 4 breast cancer patients were lower than in the other countries. But from our point of view, one of the important things that came out of that research was the great difficulty in comparing stage data across populations, because everybody used a different language. Some were using 6th edition of TNM, some were using 7, and some even, particularly the colorectal group in the UK, were using the 5th edition, because they didn't believe in the 6th or the 7th. Others were using the Duke's classification, others were using FIGO. My understanding is Norway and New South Wales used local, regional, and distant classification, but the classifications were different. So they had to be translated for the comparison to be valid. And one of the papers that came out concluded that comparative research would be facilitated if all clinicians referred to a common staging system such as TNM, but that TNM should remain simple enough for epidemiological research. And I'm sure everybody in this audience would agree with that. But as we know that stage data is important in cancer control activities, this is, again, this is 12 years old now, but this is World Health Organization Cancer Control Knowledge Interaction Guide, state that stage data is central determining cancer burden as it provides information regarding incidence, stage, mortality, and distribution of major cancer types. But stage data is not always available. This is from the Global Can prostate cancer map, and as you can see, prostate cancer is common in North America, Western Europe, and Australia, but also in Brazil and South Africa. One of my colleagues comes from Brazil, and I don't know if this is true, but he says everybody has their PSA measured every year. So you pick up early prostate cancer. In South Africa, we don't know because we don't have the stage data. We know in North America, a black population often present with aggressive, locally advanced prostate cancer. Is that what is happening in South Africa, or is it early prostate cancer? We don't know because there's no stage data. So we need to try and get stage data into cancer registries, which led to the development of essential TNM. I was at a presentation earlier this morning talking about the education in certain African communities of cancer registries with essential TNM. And the idea of this is that, not every country has enough information to collect TNM data, either because the investigations haven't been done, or even if they have been done, the data isn't collected. So you have a paucity of data, so you can't collect full TNM. So although the benchmarking concluded that everybody should use TNM, that may not be feasible. So what can you do when you don't have that information? So this led to the introduction of essential TNM. When it was developed, I wanted to call it reverse TNM or MNT, but I was appropriately voted down because I think that would have caused too much confusion. But the idea is cancer registry registrars looked, first of all, to see is there evidence of metastatic disease. If there's metastatic disease, then you know it's stage 4, and therefore you can stop looking. If there's no evidence of metastatic disease, then look for regional disease, nodal disease. If there's no evidence of nodal disease, then look at the extent of the local disease. So you can record that using simple worksheets which have been developed for breast, prostate, colorectal, and cervix. This is an example of breast, and it's linked to the pictures from the UICC Atlas, so this can help the registrars determine what it is. You start off, as I said, with metastatic disease and then work your way down. It's been translated into French. This is cervix. It's been tested in a variety of places. It was tested in Atlanta Cancer Registry to make sure it worked and was accurate. And then it's been field tested in more places than this on the map now. And it said there's an educational program. This is from a course in Addis Ababa, but I can't say. I can't. Anyway, never mind. Course in November, led by Max Parkin and Marion Pineros. And apparently it takes, we were hearing this morning, it takes about 15 minutes for the cancer registrars to do essential TNM, and with training it became more and more accurate. So I think this is the way forward in lower and middle income countries where they don't have sufficient information or resources to collect full TNM. But shouldn't be considered to be an answer for registries in high-income countries. There's a user guide that's being translated into Spanish and French. And Servmark want to increase it to other tumors as well. And we're having a meeting later in the year to try and develop schemas for that. Some are quite simple. Colorectal was a nice simple one because, as you know, colorectal fits in nicely with local being stage 1 and 2, regional 3, and but lung is much more complicated. So it's going to take a lot of work to work out how to do this and make it simple enough and to be usable. And again, pediatrics, Joanne, who's speaking later, was involved heavily with leading this process to develop a way of collecting pediatric staging that can be used globally. Pediatrics is unlike adult in that a lot of it is determined by research groups and some of it is determined after initial treatment. So it required a lot of work to get a group together and come up with a program that could be used globally to collect staging information. So there are multiple stakeholders, UICC, NCI, a Society for Pediatric Oncology, representatives from high and low middle income countries, epidemiologists and pediatricians, and even adult radiation oncologists. There were 2 of us, me and my colleague Mary Gospel-Irish, because the meeting was just held across the road for where we work, so we were cheap to be invited. But the idea is it had a tiered approach, tier 1 to, depending on what was available and how you could use it. And I'm not going to go into detail, but this is just a way of showing that in some tumors, such as rhabdomyosarcoma, it's easy to use TNM, and that's what is used. Others, there needed to be some modifications. Wilms, for instance, is one of the tumors where chemotherapy is given first, so you need to have a Y stage, Y being the way of recording that treatment is given before stage. And again, there have been a variety of pilots and been adopted in a variety of places, variety of translations. I put at the bottom query NA, so that's North America. Hopefully it's coming to North America soon. So, as you know, the 8th edition was published in 2016. I've got it right, hopefully, this time. And when we come up with an edition, I hope there'll be a 9th edition coming, probably. One of the ideas is that perhaps there'll be rolling updates, but we haven't come to grips with that yet. So maybe there'll be another edition in another 4 years' time. But again, how do we equate the different needs of the physician, the North American physician and patient who wants the most up-to-date, accurate information, and how do we meet the surveillance community in sub-Saharan Africa? How do we meet those two different needs? One idea would be not to change anything, keep everything stable, but things do change. And a big change, for instance, last year was the identification that oropharyngeal cancer can be separated into what is really now a new cancer. HPV positive oropharyngeal cancer is a different cancer from non-HPV positive and behaves in a different way. This is again from my colleague, Brian O'Sullivan. This is their work. The slide on the diagram on the right shows survival in HPV negative oropharyngeal cancer by stage, showing that it breaks down nicely by stage 1, 2, 3, and 4. The curve on the left is that of HPV oropharyngeal cancer, showing that in fact all the lines overlap apart from stage 4B. So traditional TNM did not work for that disease. So nobody wanted to use it. So you had to come up with a new TNM that worked. So you can't be completely stable. You've got to adapt when there's new evidence. So how do we cope with also the need to collect prognostic factors? There are different ways of doing that. There's the UIC philosophy, which is to keep it separate. There's the AJCC philosophy, which is, if you have it, you should need it and combine it because you need it to determine most accurate prognosis. Should that be done in a table, or should there be apps and tools to do that? And I'll talk a little bit about breast as an example. Breast, as we all know, anatomical extent of disease is important, but ER, PR, HER2 new, gene expression profile are also very important, and they're identified both by the UICC in the prognostic factors tables as being essential, and also the AJCC, who call it required, but it's essentially, sorry, I shouldn't use the same word essentially twice, but they're the same thing really, they're equivalent. So, as I said, the UICC tend to keep them separate and say, this is the anatomical extent of disease, record that, but these are the essential prognostic factors that should be known, and ideally should be recorded as well in cancer registers, although we don't specify that. So this is the anatomical extent of disease, published both by UICC and AJCC. The AJCC philosophy is that breast, in some respects, like oropharynx, in that it's a mixture of different diseases now, which have different prognoses, different patterns of recurrence, different metastases, different sensitivities to available therapies, depending on the molecular characteristics. And this is just an example of the different curves for survival depending on different prognostic factors, suggesting there are different disease types within this big umbrella called breast cancer. So these factors are important and shouldn't be ignored. But they can be combined with anatomical extent of disease. The question is how best to do it. So at the moment, AJCC produces a table with them combined. This can be converted into an app, which is a point of the development of this table. But other ways of doing it there's Adjuvant Online, or this is from the UK, this is Predict, where you incorporate and record things like age, menopausal status, or the tumor markers, tumor size, and nodal extent, and get the prognosis. So I think that there's ways, particularly in the rapidly expanding technological improvement, of developing tools to aid clinicians and patients in determining prognosis and treatment, incorporating anatomical extent of disease and also important prognostic factors. It's also important to consider what outcome we're measuring. We traditionally just look at survival as the outcome, and anatomical extent of disease predicts survival. But there are multiple different types of outcomes, and prognostic factors can vary depending on what outcomes are being measured. So there's survival, tumor response, time to various events, toxicity, side effects, reported outcomes, reported experience measures, social outcomes, return to work, and productivity, for instance. So there are different outcomes depending on prognostic factors, and prognostic factors can vary as well. So I'm a colorectal radiation oncologist, so look at, I mentioned MSI high, and but also if you look at CEA, it's not like, admittedly, it's not like PSA in that, only about 30-40% of colorectal tumors secrete it, but it is proportional to the burden of disease. But like PSA, it can drop when the tumor de-differentiates. So just a falling tumor marker doesn't necessarily mean improvement in disease. So you've got to be wary of how to interpret prognostic factors and molecular markers. There are other important things such as node positivity and node ratio. There's more and more papers looking at node ratio, but every paper has a different ratio and reporting outcome. So, but nodes are important, and they predict survival by distant disease. In colorectal cancer, one of the other factors that labeled as essential in UICC and required in AJCC is the circumferential radial margin. I'll skip that, I've shown this already. But the radial circumferential margin, which is the distance from the tumor to the edge of the mesorectum. And that's a very important prognostic factor. It determines whether we give preoperative radiation or not. But it's only a prognostic factor for local recurrence. It's not a prognostic factor for distant disease. Survival is not changed. And this is just a graph showing that if you have a low radial margin, a small radial margin, the risk of local recurrence is high. So if you look at the prognostic factors, the recommended UICC and AJCC, they're very, very similar in sort of radial margin, CA, vascular lymphatic invasion, perineural invasion, and things like that. There's some things that are different. AJCC includes tumor regression score, and that's an important prognostic factor, but it's a prognostic factor you only know once you've given your preoperative chemoradiation. So again, I'm not going to delve into this because of time, but the importance to collect preoperative information, the stage after preoperative treatment is still important to know. But it's a factor that you have to give treatment first. So it's not classically a stage prognostic factor, which is things that we think of before any treatment. So how are we going to deal with prognostic factors in the future? I think we need to sort of list prognostic factors, and in high-income countries, you should be able to collect age, performance status, social determinants of health, grade, histology, and to some extent of disease, but also essential and required and additional prognostic factors should be collected. But what do you do when you don't have, if you don't live in a high-income country? I think we still need to, sorry, I'm skipping myself around. I've lost track of what I was trying to say, but never mind. So I know what I want to say. What I want to say is high-income countries should collect everything, but that's not practical. So you've got to decide exactly what you can collect. Many things are difficult to collect because you can't find it. But I think both UICC and AJCC need to work together with the registrars to determine what should be collected and what can be collected. And that's ideal for high-income countries. In low and middle-income countries, I think you could have a tiered approach. As with essential TNM, you could collect prognostic factors that are essential if they're available. And should we expand essential TNM in the future to include essential prognostic factors if they are available? So I think that some work that needs to be done is trying to work out what factors are essential and how and if they can be collected. So what should we do with the 7th edition? I mean, this is, again, what I'm saying is my own personal opinion, is that I think we should try and keep anatomical extent of disease as stable as possible. You know, I think there are some changes that have been made with very little evidence for change, or there may be a statistical benefit, but it may be that it's only a small benefit, and is it really needed to change? So I think we've got to be very wary of what we change just for the sake of change. But there may be situations where there is a major difference or major correction needs to happen, or a new disease. So I think you need to have some changes anatomical extent of disease. Some sites could be simplified. We need to have a more global input to change. I think UICC, although we have TNM committees in many countries and cover 60-odd% of the population, are not very good at including them in feedback and change. And I think we need to have a more global view in changing additions. We need to make sure that essentially TNM is developed with each change. And I think we need to ensure there's collaboration in determining essential and required prognostic factors, and perhaps developing a tiered system. And I think in this era of technological advances, I'm sure there will be different tools will be made available for the physician patient to determine prognosis, depending on outcome you want to measure, and also appropriate treatment. So that's it. Thank you very much. Thank you.
Thank you, Dr. Barley. We have time for about 10 minutes worth of questions, so please come up to the mic and ask your questions.
I found the pointer right at the end, so.
Okay, is this on? Okay, great. Okay, Jim, Hannah Weir, thank you for a very wonderful, great presentation. I want to press you on something you said, though. So just because we can doesn't necessarily mean we should, and I'm trying to figure out, and I'd really like your thoughts on this. From a population perspective, any guidelines or guidance on what we should collect in terms of prognostic indicators? I mean, as you alluded to, a lot of this information is well beyond the typical reach of what population-based cancer registries can collect. So distinguishing between hospital-based registries and population-based. So just your thoughts.
I think that's very difficult because I said, I mean, I think it also depends on what's going to be available. But I mean, I use the example of breast because all those factors, ER, PR, HER2 new, are so important in determining both prognosis and treatment that I think they should be collected, but they may not always be available. And that's why I think there may need to be a tiered approach in collect what's available. And I don't know what's available in some places. It may not be available. So, and I don't really know how you come to grips with this conflict. I mean, apart from developing working groups like we did with Essential TNM, with a variety of stakeholders who know A, what's important, and B, what's available. But I know this is an issue, certainly in the North American situation with the AJCC, and particularly in where you have multiple offices and multiple places where the data may be, trying to get it all together can be very difficult. So at a population basis, it can be a major challenge. But I think that, the AJCC philosophy to say that breast is a multiple different diseases, perhaps in the future when there's more evidence, you can actually then select how those diseases and just look at triple negative breast cancer as a separate disease like we've done with HPV positive oropharynx. Is that the way forward? But then you're going to need those prognostic factors to determine what that disease is. So yeah, it's a sort of chicken and egg, and I don't know the answer.
Yeah, I think AJCC came up with, 64 versions of breast cancer? when you put all the prognostic indicators in. So it's a challenge, and I know there's no simple answer to it. Thank you.
So can I heckle you now, Jim?
Yeah.
So I really was interested in, this was a great presentation, thank you. And one of the things that we think a lot about are sort of these giant multi-gene panels, the somatic mutation panels like Foundation Medicine, Caris Life Sciences, which are constantly expanding the genes that they're testing. And how does that fit in? And, you know, is there some point in time when that may sort of override the prognostic value of anatomic staging? Or could you comment on that?
When I was on the plane yesterday coming over, I ended up sitting next to people who've been on a medical leadership conference of some description, and they were asking me what I thought the next big thing in cancer is going to be. And I said, well, I always remember when I was a medical student in the late 70s and interferon came on, and interferon was going to cure all cancers and we would all be out of a job. I think like this, I mean, I think there's some things, it's like radiation oncologists. Radiation oncologists are always being threatened, there's not going to be a job for you because there's going to be all these things that's going to replace it. I think there's still going to be a real need for anatomical extent of disease in many diseases. And I think, you know, these tests may help identifying different disease subcategories, but I think the majority of things such as are still going, you know, even if you look at triple negative breast cancer, if you have stage 1 disease, your prognosis is much better than if you have stage 4 disease. So it's anatomic extent of disease, I think, is still going to be important. It may be relatively less important, but, you know, I was asked to talk about global cancer staging, so I thought I could ignore all those things.
Can I ask one more question? Is that,
yeah.
Do I? Okay. So I really am also very intrigued. I don't know if you saw Alison Van Dyke's presentation yesterday about digital pathology and digital images.
No, I was on the plane.
Oh, okay.
Having my conversation
anyway,
about...
So one of the things that we're thinking about in SEER is the acquisition of digital path imaging, because there are important factors that generally the pathologist doesn't always describe well in the text document. Things like nuclear pleomorphism and tumor-infiltrating lymphocytes and things like that. And so what's your thought about like integrating some of the information from those digital images into staging?
Well, this goes back to, you know, what I was saying about the big sort of conflict in staging. What do you call stage? I mean, the UICC, in some respects, are a bit negative in that and think of stage only as a description of anatomical extent, whilst AJCC thinks of it as in broad terms, including prognostic factors, including all these things that you're discussing. And I think, you know, there may be a role with time and evidence to show that this is effective, and developing tools, but they're going to be very much the individual prognostic factor and treatment for that individual. And I'm not sure how that translates into the population-based cancer surveillance activities, certainly not in the global context. And I don't really know quite how you balance that conflict. I mean, will you be able to group enough people so you can have a look at a population basis when you're getting such individualization? I don't think so. So you're still going to need some type of way of getting a population together rather than an individual. So I'm sorry, I'm not doing very well in answering questions.
I have a good question for you, though.
Can I answer? Will it have an answer?
So, from a large cancer hospital in Houston, Texas, MD Anderson, I wrote a paper with a urologist about 10 years ago showing that SEER staging is better for prostate cancer than AJCC7, because lymph node involvement is regional in SEER versus in AJCC, it's stage 4. And we showed the survival difference between AJCC versus SEER. So I didn't hear much talk about SEER, but I get the fact that AJCC, from a clinical perspective, the clinicians and surgeons prefer that. What I find interesting now is there's a discussion from our pathologists stating that they just want one stage, AJCC. The problem with one AJCC, and of course the pathologists believe that it should be pathology staging, is our clinical staging is oftentimes more relevant because of the downstaging impact you see from neoadjuvant therapy. So what are your thoughts on, is there a movement towards just one AJCC staging, and the issue with clinical staging sometimes being more upstaged than with the neoadjuvant staging, it's more accurate actually than the downstaging you'd see after neoadjuvant therapy for pathological staging?
I'm not sure I'm going to answer that question either, but I think clinical stage is getting to be more and more important because so many situations surgery is not being performed.
Right.
So, and I come in from a center where there was more surgery for prostate cancer than where I trained in the UK, where surgery was rarely performed. Now there's a bit more surgery. Other places now, the amount of surgery of prostate cancer is dropping, so you have to rely on clinical. And then there's big debate now about what you collect when you're giving neoadjuvant therapy and what happens when neoadjuvant therapy, the patient doesn't have surgery at all. So it's going to get more complicated. I think you still need to have clinical and pathological because you don't have the two. And I think, Elizabeth presented data from the Belgium Cancer Registry confirming really what you said. I mean, UICC actually diverges a little bit from the AJCC when it comes to nodal status, and with T4 and nodal status not considered to be stage 4, but she showed that in fact if you put it in stage 3, it doesn't really belong stage 3 either, because T3 and 0 is not in stage 3, and is in stage 3 and they do much better. So I think there's always going to be these things that are not perfect, and I think that's where having some degree of stability helps, so you can compare across it. But I think we do need, that's why I say we need more global input when it comes to developing and changing stage, so we're not just reliant on one source. So we need more population-based input to look at questions like that. Where should nodes go?
Well, you answered my question, so thank you.
Thank you.
Thank you. So there is a thirst for data in the surveillance community, whether it's additional molecular characteristics for stage, or prognostic factors, or to fill out some more longitudinal data to capture the full cancer patient experience. There's a thirst for data. And the solution is not to throw more CTRs at it. There just simply aren't enough, and they don't appreciate being thrown. I happen to know something that will help with this problem. I don't know the solution, but I know it's something that will help. Does anybody know what that is? Can you call it out? The answer is informatics. I am biased, and so are you. So I'm happy to say that we have an informatics expert and specialist as our next speaker. Dr. Lynn Pinberthy is the Associate Director for the Surveillance Research Program, which is within the Division of Cancer Control and Population Sciences at the National Cancer Institute. Dr. Pinberthy obtained her MD from the University of Michigan and her MPH in epidemiology at Johns Hopkins. Dr. Pinberthy's career includes a surgical internship in Baltimore, Maryland at the Sinai Hospital and a preventive medicine residency at Johns Hopkins University. After her residency, she completed her postdoctoral training in epidemiology with the CDC as an epidemic intelligence service officer with the Commonwealth of Virginia. She is licensed to practice medicine in the state of Maryland. And although she doesn't have informatics in all of those titles, she understands the importance of informatics, and she is an innovator and a visionary and a wonderful person to collaborate with. So without further ado, Dr. Lynn Pinberthy.
Oh, thanks, Isaac. Gee. So I have to be, really transparent here. I'm really an informatician wannabe. Okay, so I'm not truly an informatics person. Is this it? Okay. So thank you so much for giving me the opportunity to be here today to talk to you. And anybody feel free to heckle me, except for the person down on the end there. So really what I want to do is throw out a challenge today for all of you to talk about the changing paradigm that we need to face in cancer surveillance. And I think Jim really identified a subset of the problems that we're facing. And so what I'd like to do is really reflect on some of those, to talk about the importance and utility of registry data for research. I think you know this, but there's a slightly different spin that I want to present on that. To talk about the changing landscape of cancer surveillance, excuse me, and associated challenges that impact our surveillance systems, and then identify some of the important areas that cancer surveillance needs to address to be meaningful and relevant today. And then lastly, provide you some examples of some new initiatives that we're doing in the SEER program that help us to enhance our data and that meet some of those challenges. So to talk about some of the value of surveillance data in the real world, and I like to think about real world data because there are a number of new entities that are arising, such as Flatiron, IQVIA, and others who talk about real world data, but registries are very different in that they represent data on all cancer patients in a defined geographic area, not just from a single center or hospital system. And that's very important because it permits assessment of community as well as academic center patients. And in fact, many real-world data sources that I just mentioned represent a non-random set of patients from a single center or EMR, and they may not really reflect what's going on in the 85% of patients not treated, for example, at NCI-designated cancer centers or within those EMRs. And registries also, central registries, consolidate information from across many sources, and this is incredibly important because typically there's more than one source of information that's used by, for example, SEER registries to complete each cancer abstract. In fact, there's about 4 records per case that's abstracted. And those include data from the sources that are listed here, as well as we're starting to increase additional sources from which we receive real-time data feeds, such as from pharmacies and oncology practices. So again, what you all perform is active monitoring of patients from the time of diagnosis until patients die. And I think it's important to reflect that most of the data that people are using for research studies are lacking in outcomes to provide context for data sets, such as TCGA, clinical trials data, and pharmacy data, or pharma data. We also have many structured data elements that have key clinical data about each patient. And as you know, any of you who have participated in research, it's extremely costly for investigators to pay for structured data collection, to do this abstraction on their own. And in fact, more than 65% of the critical elements that people need for research come from EMRs, and it's held in unstructured data, which is very, very difficult, as you all know, to abstract that information. The data in central registries are curated and adjudicated by trained and experienced personnel, and that's very important because while we're not perfect, the consolidation, manual review, and often centralization makes the data highly accurate and more complete than many other data sources. Okay, so as I mentioned, we're not perfect, but we're very good, but there still are a number of challenges that we are facing to make our data clinically relevant and meaningful in today's oncology world. So I'd like to go through some of these challenges because I think it's important for us to think about them. The first of these is, as Jim mentioned, is that the current manual abstraction process, at least in the SEER program, requires a registrar to manually abstract over 215 different variables per case directly from the EMR, and often from many different EMR components. The data elements are often very complex, and I think Jim really described that very well in terms of staging. And I think it's interesting to point out here that registrars need to know all 118 different schemas, either for EOD or TNM, whereas a clinician may only need to know 1 or 2 because they tend to be focused on one disease site or one organ system. There's, in the US at least, and I think this is probably true in many other countries, but not all, there's a huge diversity of healthcare organizations where patients receive care, and those organizations may have provide limited access or no access to registrars to collect the data. And this is just a cartoon that I know some of you have seen before, but I think it really represents very well what's happening in the US. It's a very, very complex system. And so to be able to negotiate that both for us and for the cancer patients is really challenging. There's also a rapid pace of change in cancer diagnosis and treatment, and that makes it particularly difficult for us to maintain relevance. A couple of examples that I wanted to mention are, for example, liquid biopsies. They're changing the way both that we diagnose and the way we follow patients over time. And so we need to think about integrating this new information into our systems. We also have new data sources such as digital imaging for path and radiology. That's a scheme that obviously I'm a little focused on right now. But I think it's incredibly important because there are features that can come from digital images such as the path images that are incredibly important prognostically, such as tumor-infiltrating lymphocytes in colorectal cancer patients. And so we need to think about that. And at least in the US, I think there are many organizations that are starting to digitally image all of their slides. And so I think that that's incredibly important. And I want to just throw out, this is a thought that I've had with some of our discussions that I've had with some of our folks in global health at NCI, that this may be an opportunity for less well-resourced countries, because the digital images can now actually be, you can adopt like an iPhone to take pictures of a slide, which would allow the image to be sent to other areas for reading by pathologists. I also think it's really important to point out that there's this very, very rapid pace of change in new therapies that are being approved. So for example, in the US, the FDA approved in 2018 nearly 90 new IV therapies as well as 75 oral anti-neoplastic therapies. I mean, this is huge. I would also add that our current manual abstraction process is slow. The data aren't timely. And with the rapid pace of change that you've just seen, the 2-year delay that we have in our data really reduces the value of the data. And in fact, as I mentioned earlier, registrars may not have access to the appropriate information, such as outpatient-delivered chemotherapy and testing, pharmacy-delivered oral anti-neoplastic therapy, and then multiple courses of therapy over time beyond the initial course. We also need to think about capturing outcomes other than survival, such as recurrence. The good news is that patients are surviving, which is fantastic, but now they're getting one or more recurrences, and so we need to be able to think about cancer as a chronic disease, and that requires us to capture long-term measures of outcomes, such as recurrence, subsequent courses of therapies, and of course, the comorbid conditions that can impact what therapy the patient has, as well as their potential resulting from the therapy that they might get in their first or second courses. There are a number of challenges to capturing recurrence, and I just want to spend a moment or two talking about that because it's very, very complex, and that's why we haven't done it to date, because the diagnostic methods for recurrence differ by cancer site and by provider, and it can include one or more of the following different methodologies, such as biopsy, imaging, serologic tests, Jim mentioned CEA, signs and symptoms, et cetera, and that can come from a number of different sources. In addition to that, there's a differential time from diagnosis to recurrence and risk of recurrence depending on the cancer site. For example, there are marked differences in colorectal and breast cancer in terms of the time to recurrence for those cancers. Registrars are often unlikely to have access to some of the heterogeneous data sources from which evidence of recurrence would be derived. And I'm not going to go through all of these here because you can read them. But I do want to point out at the very bottom of the slide that as technology advances, such as with circulating tumor DNA and liquid biopsies, when and how recurrence is diagnosed is going to change. So for example, we may see fewer and fewer shorter disease-free intervals from diagnosis to recurrence as we're better able to capture that recurrence information based on tests such as these. So I want to just sort of make the argument to all of you, really, why we need to begin to capture this information. I mean, we saw some of the challenges, but why is it so important for cancer patients and for researchers? So why do we need detailed treatment? Well, real-world treatment data from registries would allow us to study really important questions around affordability, which is critical in the US at least, adherence and compliance to these agents, especially the oral treatments, and then disparities in who receive these treatments. One example is that in 2012, 12 of the 13 new drugs that were approved for cancer indications were priced above $100,000 per year, which is ridiculous, at least in the US. And, well, it's ridiculous everywhere, but the cost was in the US. And I just wanted to say that some of the new immunotherapies that we have today cost over $1 million in the US, and the out-of-pocket cost to patients can be as much as $200,000, which is just not sustainable or really even feasible. We also need genomic data. And that was part of the reason I asked the question to Jim, but how patients are being treated is changing a great deal based on targeting mutations. And these mutations, it's important for us to note, that may represent only a small subset of the cancer population. And the use case that I'd like to mention here is non-small cell lung cancer. I'm specifically looking at EGFR and ALK. And I have to add that EGFR and ALK are kind of the old biomarkers. We're also now need to do ROS, BRAF, HER2, et cetera. So it's just an ever-expanding number of important biomarkers that people need to understand to be able to predict response to therapy. And I think that it's important because EGFR and ALK mutations can really be beneficial to the patients. They have good response to therapy if they have these mutations. And however, EGFR is only, we think, there's only a mutation in about 19 to 40% of the lung cancer patient population, and ALK even lower, from 2 to 7%. And so that means that we need to look at every single patient who may or may not get tested to see if they have a mutation and to understand the quality of care that they get. So this is sort of one of my favorite examples, and I got this from one of my colleagues, Donna Rivera, who's a pharmacist, and really gives you a good idea of why it's so important for registries to capture and represent real-world data. Because randomized controlled trials cannot test all permutations of cancer situations. As you well know, in the US, about 5% or less than 5% of cancer patients are enrolled in clinical trials. And those patients tend to be younger, they tend to be white, and they tend to have very few comorbid conditions. And so once it gets approved, it's used in the 95% of patients who are not in those clinical trials, who are often old, sick, and not white. So we really need to understand how well it works in those different permutations. And the example I wanted to talk about is lorlatinib. The efficacy was established in late November. It was approved in late November of 2018, and it was based on 3 clinical trials for a total of 55 patients in 3 trials total. It was pediatric and adult, and it looked at 12 different cancer types with metastatic disease. They found that the drug was very effective, but really this small sample size doesn't help us understand how it might work in the larger population. And so I'm going to give you more information on this in a few moments, but looking at some of the near real-time data feeds that we have from our pharmacies in the US, from CVS and Walgreens, will allow us to monitor the dissemination of these agents over time, to look at adherence and compliance in these patients, but also allow us to complement the information that we get from the clinical trials to look at different population subgroups, different age groups, and even patients with comorbidity. So I'm going to go back to recurrence because I'm really obsessed with recurrence right now, and it's one of our goals for this year. But I think it's so important because we have almost 17 million cancer survivors in the US right now. That's almost 5% of our population. It's enormous. And really, our lack of recurrence information is just no longer acceptable. We have to be able to do this. And in fact, in addition to that, many of our clinical trials are really focused on recurrent disease. And in fact, most intransigent cancers with the highest mortality are likely to manifest with recurrence and metastatic disease, such as pancreas, ovarian, melanoma, and glioblastoma. Okay, so I want to just talk a little bit about the approaches that we're taking in SEER to really offer as a prototype for how we could all do this to improve what we do in cancer surveillance. This slide shows the data sources, both current, which is on your left, and then the new data sources that we're either testing or piloting on your right. And really what we're trying to do in enhancing SEER is to create a system that represents population-level real-world data that can supplement and complement clinical trials and help us understand the effectiveness of oncology care in the 95% of patients who are outside the clinical trial setting. And we're doing this through an incremental approach using small demonstration pilots that allow us to test methods cost efficiently, to identify and address some of the barriers and the challenges, and then we can scale to the entire SEER program or other registries as well. That allows us to create a longitudinal picture of each cancer patient's trajectory from diagnosis until death. So we're doing this really to enhance completeness and to expand the clinical data that we collect. And it's through two different general methodologies. One are through linkages, the other is through automation and NLP type tools. The linkages really allow us to improve the efficiency of capturing both new as well as existing data items. They're cost efficient. We have increased accuracy, and in fact, often we can get real-time data because many, and improve the timeliness because many of these sources are available in real time. And it allows us also to incorporate data that could not be done manually. For example, some of the large genomic panels that I mentioned earlier when I was talking or asking Jim the question, such as Caris and Foundation, which each have between 600 and 700 different mutations that are being tested. And it's not feasible for a registrar to be able to capture that information. We've also been working with, largely through our partners with the Department of Energy, to develop tools for automation, NLP and deep learning, which will allow us to reduce manual abstraction and also increase accuracy, consistency, and even timeliness of the data, because often this can be done in essentially real time. And we're leveraging all of these activities through collaborations with external partners, both commercial and public, and I'll talk more about those in a few moments. So the gaps that we're really trying to address, we have several focus areas. So data capture, and then helping to develop a new infrastructure for the SEER program to support cancer research, because we are part of the NCI, and our primary mission at NCI is to support cancer research. In terms of data capture, we're really focusing on 4 areas. The first is to capture detailed longitudinal treatment, to capture comprehensive genomic data that characterizes the cancer, to capture outcomes other than survival and cause of death, recurrence specifically, and then comorbidity to provide context for therapies and outcomes. We're also working on 3 major initiatives to develop an infrastructure to support cancer research, and I'm not going to talk more about these in this presentation, but I'd be happy to discuss them with you offline. The first is a SEER-wide mechanism for rapid case ascertainment for patient eligibility assessment for clinical trials and other studies, which many of our SEER registries already do. We're trying to do this on a scaled level. The virtual pooled registry, which was in the concurrent session just before this, and the virtual SEER-linked biorepository, which was talked about yesterday morning. As I said, we have a number of partnerships that we're developing, and we found this to be extremely efficient. We're working with organizations to acquire the source data, because then you don't have the risk of, translation errors, interpretation errors, et cetera. With genomic and genetic testing companies such as Genomic Health Incorporated, Foundation Medicine, Caris Life Sciences, and Myriad. We're also looking in the US at claims data sources, because they are a very structured data that use consistent coding systems such as HCPCS codes, CPTs, ICDs, et cetera. And we have 4 sort of major initiatives in that area. The first is working with Unlimited Systems, which is an oncology claims provider in the US that has about 2,100 oncologists for which they do this service. We're also talking to large commercial insurers in the US. The first of these is United Healthcare, which is the largest commercial insurer in the United States. And I think they may even have international coverage, but I'm not certain. We're very close to having a data use agreement with them, and we hope to have data by the end of the year. And then we're also speaking with some of our registries. 6 of our registries have what we call all payer, all claims data, which has a consolidation of different claims data from different insurers. And then lastly, as I mentioned earlier, we've been working with CVS and Walgreens, which are large pharmacy providers in the US, and those of you I think in England and UK and elsewhere may know them as Boots, is Walgreens. And we've done this initial pilot study in Georgia, and we're now in the process of scaling to the rest of the SEER registries. But we also have partnerships with technology companies that aggregate and use clinical data. And these include organizations such as CancerLink, which is a subsidiary of ASCO, SciAps, and Tempus, as well as working with other companies such as Varian and Electa to capture radiation treatment. As I mentioned, we've been working with our DOE partners to use automation to reduce the manual burden and to improve timeliness. And the goal is really to leverage deep learning mechanisms to reduce the burden on cancer registrars and to capture more consistent data. But I have to say, we're always going to have some manual adjudication and decision making, but we'll try to automate where we can. And this frees registrars, including the central registries, to really focus on things that the computer can't do yet, such as staging, And then it allows us to have an opportunity for real-time data capture. So the initial focus of this effort has been on path screening and automating data capture for 5 key variables: histology, site histology, laterality, behavior, and grade. And then the system will now automatically extract these 5 variables and will place a probability around the answer being correct. So I think that's really important and is an advantage over some of the existing systems, because it provides a confidence interval that the registrar can look at to determine whether or not they want to review that particular variable and that path report. So now I'd like to move on to some of the current pilot studies that we have to really give you a flavor of some of the exciting things that we can do with some of these new tools and methods. And really, this is sort of the changing paradigm that I get very excited about. And I wanted to provide some examples of what we can do with these data. So we're beginning to collect data that will permit us to expand what we capture from radiation therapy, to track and monitor dissemination of specific treatments over time, to evaluate standards of care in oncology practice, and also to corroborate clinical trial results in the real world, which, as I mentioned earlier, is really important for us to be able to do. We need to represent trends by more clinically relevant categories, and then doing so where feasible using automated deep learning and data extraction. So radiation treatment, as you know, we currently collect sort of minimal data on the initial course of therapy, and so we've been working with Elekta and Varian to capture selected structure data from their EMRs. This will allow us to have increased detail, including the dose, as well as automatically providing information on both the initial as well as subsequent courses of radiation therapy. And this is so important because it gives us an opportunity to start to capture recurrence. And I told you I'm obsessed with that, so that's really exciting for me. We have some pilots in process that are being done in collaboration with Astro and with multiple healthcare facility sites. The first of these is Northwell Hospitals, which has both Elekta and Varian. We've expanded to a Seattle-based Elekta practice, and now we're working with Yale and a large multi-site practice in New Jersey to start to capture this information. And once it's successful, we'll be able to scale to the rest of the SEER program. And so this is just an example of some of the data that we acquired from the Northwell Hospital system. And as you can see, we have the site, the technique, the modality. I don't have the dose here, but we are receiving that. And again, just to underscore the importance of this, because this is a data feed that once we have it in place, it's going to give us the initial as well as all subsequent courses of radiation therapy. So this is an example of how we can track the dissemination of specific therapies over time. And this is very exciting. This is from the oncology practice claims that I mentioned earlier. And this is 4 years of data, and it looks at the dissemination of checkpoint inhibitors by specific entity over time. And I think what's really cool about this, the little arrow points to the end of the first quarter of 2019. And so we're getting data in real time for this. So we can track things almost on a daily basis of what's going on. So this is very exciting. This is actually a table that is from the same set of data. And I think it's really important because what we're able to do with this is to understand both the approved use of these drugs by cancer site as well as off-label use. And so this is an opportunity at the population level to really start to understand, the off-label use and what are the outcomes when patients are receiving this treatment for non-FDA approved indications. This is some of the data that we received in the initial pilot in Georgia from CVS and Walgreens. And I have to say, this is so important because in the US, CVS and Walgreens represents between 45 and 50% of all of the pharmacy data. And so as we scale this, this is getting really close to, or not close, but it's approximating the population. And I mentioned earlier that we're going to be linking with United Healthcare, and they have a large pharmacy benefit management system, which has probably another 10%-ish or so of the pharmacy data. And so I think this is really unique information, and I think incredibly important. And I hope I can convince you of that. And this is a slide that just looks at tyrosine kinase inhibitor use by cancer site and target in the Georgia data from 2013 to 2017. And I think what's important here is that this is really sort of early on and tracking over time. There were 1,700 patients just in Georgia alone with over 20,000 fills who received these drugs. This is an older slide, so I don't have the updated information. But I think the other point I wanted to make, which is not on the slide, is that overall, we had 125,000 patients from 2013 to 2017 who had at least one prescription for a specific anti-neoplastic therapy. This is enormous. This is in Georgia alone, okay? And so just to give you a sense of the magnitude of this, and we really need to start to collect this information. I can't underscore how important this is. This is another example of how we can use our data with linkages to evaluate standards of care. And this is from a paper that was published in JCO a couple of weeks ago. And it looked at BRCA testing among patients with ovarian and breast cancer. And this was a linkage with Myriad and 3 other genetic testing companies that was done in Georgia and California. Dr. Stephen Katz and Dr. Allison Kurian, and then of course our colleagues Kevin Ward and Dennis Steepen from California were very engaged in this process. And I think the important message here is that, as you probably know, all ovarian cancer patients should have a test for BRCA at the time of diagnosis. This is the first opportunity that anyone has had to look at the testing proportion of women who are tested at the population level. And sadly, it was only 31%, and there were marked variation by race and ethnicity. And so this is kind of a benchmark that potentially oncologists and others could use to help improve and meet the standard of care. This is another example of taking a clinical trial result and corroborating it at the population level. So this is for Oncotype DX21 gene assay, in which we corroborated the clinical trial result in over 38,000 women in the SEER program. And fortunately, the Oncotype risk score category actually predicted breast cancer-specific mortality, so it mimicked what we saw in the clinical trial. And then this is sort of the last example that I wanted to talk about. We really need to think about representing trends of our data in much more clinically relevant categories. And this is in SEER Explorer, which is a new application we're developing at SEER, thanks to Angela Mariotto and where you are. But it's so important because, for example, lung cancer histologies, there are very different mortalities and survivals in different histologies, different treatments. And so it's important for us to start to present these data in categories that are relevant to understand the outcomes in the context of all of these other complex data that we have. This is another example of breast cancer by the molecular subtype. And I think also to think about, if you have breast cancer and you're a woman, you want to see what the survival is for your molecular subtype. I mean, to see something by breast cancer overall really is not very meaningful. And so to have this by subtype, I think, is incredibly important. And this is something I think we can all do. I did say I would talk a little bit about some of the preliminary results from our automation. And these are very early results. So I talked about the path screening task where the registry gets the ePath report, someone looks at it for these 5 variables. And so we were able to do a time study, a time efficiency, I guess it's called, to look at what it took to manually complete the path screening for those 5 variables based on 2.2 million manual tasks in 10 SEER registries who are in SEER DMS. And it was really good, 0.93 minutes or 55 seconds per path report, so that's pretty fast. Except that the automated algorithm was able to process in 12 milliseconds per report. So huge difference. And what we found is that in the scaled algorithm testing across 11 SEER registries, which was 3.3 million path reports, we found that we were able to correctly extract all 5 data elements in 43% of the reports, which is huge. I don't like to use that word, sorry. Anyway, so what I wanted to also point out is that if you think about this in terms of, savings of our workforce, even looking at the 43% and based on 43% of 616,000 path reports where we had all 5 data elements, that would have taken over 4,000 hours for the manual process. It took 53 minutes for the algorithm to do this. So huge time savings. And this is really important because it's useful in case identification and other registry operations. It potentially reduces effort. And also, I wanted to point out that this will be available to all registries, not just the SEER registries or other central registries, but hospital registries and even to commercial entities. So this is, I think this is my last slide, but I really wanted to, I love this slide, and you've probably many of you have seen it, I know, but I think it's so important because it really reflects what we're trying to do with surveillance right now. And it shows, these are use cases of different patients. The first two are breast, the third is lung cancer. And it shows how we can link these data and really create a trajectory of each patient over time, looking at the treatment that they received and their outcome, their survival time. And what I like to do is really focus on, this is a young person with stage 3C melanoma who had a BRAF mutation. He was diagnosed in September of 2015, and he had a biopsy followed by a wide excision. And he was started on ipilimumab about 2 months later, and unfortunately had metastatic disease, groin mets, a year later in October of 2016. However, he was started on 2 oral anti-neoplastic therapies, which we wouldn't have had unless we had our linkage with the CVS Walgreens data. And the good news is he was alive as of 6 months ago. So I really think that this illustrates what we can do with our surveillance data and the kinds of tremendous information that we can represent for our patients and our researchers. Thank you very much.
Thank you, Lynn, for this inspiring lecture. I propose that we take the questions after the talk of Professor... Oh, you can? Okay. So if there are some burning questions, please go ahead. Take the microphone. I see people running. Don't run out, but Jim has one question for you.
It's not really a question, it's just a comment, because I mean, one of the things I treat is anaplastic thyroid cancer, and there's now great data to say that dabrafenib, and I can never say words with more than 2 syllables, I struggle, is effective, but it's only proven on case series of 14 patients and led to FNA approval. And we're never going to get good data without this sort of amazing work that you're doing. So thank you.
No, you're welcome. It's everybody here who's doing it. So.
It is my pleasure to introduce the next speaker, Professor Joanna Aitken. She will present the Australian Cancer Atlas development and interpretation of it. Professor Joanna Aitken is General Manager Research and the Director of the Australian Childhood Cancer Registry at Cancer Council Queensland. She holds different academic appointments. Above all, she is a very distinguished research scientist who has worked in the field of cancer epidemiology for the 25 past years. She's heavily involved and a motor for pediatric cancer staging, and also with a special interest on recurrences. Joanne is president-elect of the International Association of Cancer Registries, and she will take over from Tomohiro Matsuda, and we are sure that she represents really female epidemiologic power and natural charm. Please go ahead.
Thank you, Lisbeth. I'm glad that you introduced me. Thank you very much. You always say such lovely things. Well, after those 2 brilliant talks today, we'll all just step down a level because I'm going to just talk about descriptive epidemiology. Not staging, not genetics, but straight descriptive epidemiology. And in particular, I'm going to talk to you about cancer atlases. The Australian Cancer Atlas. And it's really important before I start that everybody knows where Australia is. So I know, I know that everybody in this audience does know that, but just to be sure, that's it there. It's about the same size as Canada, bigger than the United States, but we only have 25 million residents. So on average, that is 3 people per kilometre, per square kilometre. So we're one of the most sparsely populated continents in the world, but also one of the most urbanised. As you can see from this map, this is a distribution of the population map. The palest part is less than 1 person per 100 kilometres, so there's not many people that live in the centre of Australia. The next pale part is 1 to 10 people per 100 kilometres, And the most dense parts, which I hope you can see from the distance, the little red parts are where the majority of our population lives. So we're highly urbanised, but we're also very decentralised. So there are still major centres of healthcare and services all around Australia, and that is an enormous problem for equity in service and in survival for all diseases, not just cancer. I just wanted to show you this. This has nothing to do with my talk, but I just thought it was so cute because this is, someone's actually done a map of the distribution of species of ants in Australia, and it's very similar to humans. So that's that. So life expectancy in Australia is one of the highest in the world, about 83 years. Cancer survival has increased similar to other first world nations from 50% in the 1980s to now 70% overall. But these benefits have not been distributed evenly by any means across the population. We have huge inequities, geographical inequities, but of course the underlying reason is not geography. Well, in some cases it is, it's pure remoteness. Excuse me, but a lot of the social determinants of health, of course, are distributed with remoteness. One of our well-known epidemiologists, Bruce Armstrong, has published in the Medical Journal of Australia, and this was before the federal election, before the last one, when the point was trying to be made that one of the preeminent health challenges faced by our nation, by Australia, is to achieve health equity for all people, regardless of where they live, regardless of their race and regardless of their income. That was in 2007, it's now 2019. We've just had another federal election, and this could have been said exactly the same way before the most recent one. In fact, it was said by the Cancer Council Australia, our preeminent cancer organisation in Australia, non-government cancer organisation. So we still have huge inequities, and they're getting worse. The first step in dealing with inequity is to understand it, to really understand what the differences are and where they are, and they're not always where you think they are. So that's where cancer mapping comes in. I know that many people in this room have been involved in cancer mapping and in doing the same techniques that we've done. But I'm going to tell you, the rest of the talk now is going to be about mapping, about cancer mapping, and then I'm going to give you a little demonstration, and my hat's off to the AV team who have helped me with this. So I'm going to do a very courageous thing, which is get onto a laptop in front of all of you people and try and make it work. I'm sure it will, because it has done now for quite some months. I didn't mean to say that. So this person is Dr. Alfred Haviland. In 1868, he gave one of the first lectures demonstrating that cancer should be considered as a distinct public health concern, and he was the first one to use a cancer map. This is a map of female cancer in the English Lake District in Cumberland and Westmoreland. He switched the colours around. Red means low rates in this map and blue means high rates. And he even did this by age. So the one on the left is all ages and the one on the right is women above the age of 35 years. Now skip forward to exactly 150 years as it happened, from 1868 to 2018, last year, with the media release of our Cancer Atlas, which I'll talk to you about now. And there is our two very distinguished Bayesian statisticians who got into that, photobombed me in that picture. How could we get from Dr. Haviland's map to what I'm going to demonstrate later, our map, in 150 years? Why did that take so long? Well, we needed four things. Obviously, one of the fundamental things, and why we're all here today and why we've spent such a wonderful time together talking about this item, cancer data. Australia has had for some time complete cancer registration, excluding, of course, the keratinocyte skin cancers, which in pure numbers in Australia outnumber every other cancer about 10 times over. And if we were to collect those, it would completely swamp us. So we don't collect BCCs or SCCs, but we collect all other cancers. And this is done on a state basis. We have 8 states and territories around Australia, and I apologise if there's any Tasmanians in the room. There is another state down the bottom, Tasmania. Are there any Tasmanians in the room? And that's clearly not enough to do a high-resolution map. We need much, much finer resolution. So Australia is divided into statistical areas, or for census purposes, 2,147 spatial areas, SA2s. I'm sure you have the same thing in Canada and the United States. And we needed to do a high-resolution map. We needed to be able to map each one of those cancer cases to one of those areas. So we need very good geospatial location details for every single cancer case. This we now have in registries. All of our registries now have a similar, not identical, but similar system of GIS coding for cancer patients, which allows us to map each case to one of those little SA2s according to the residential address of the patient at the time of diagnosis, which is what we want to know. We don't want to know where they're treated, but where they live. So the idea was to calculate for each one of those little tiny areas 2 measures that we were mapping: cancer incidence rate, which we call cancer diagnosis rate because it makes more sense to the general public for whom this atlas is supposed to be, by whom this atlas is supposed to be used, is 1, that's cancer diagnosis rate, and the excess death rate, which was calculated from the relative survival estimates, and basically is just the number of the rate of excess deaths above and beyond what one would expect in the general population without cancer. And these 2 are cancer-specific measures, which we've done for each of 20 cancers and for all cancers overall. And as I'll show you later, the map is really about communicating geographic variation. So we didn't put the actual rates are not mapped. It's how far away from the Australian average an area is. If an area is very low diagnosis compared to the average, it's a blue area. Very high, it's red. And the same thing applies to death rates, or excess death rates. The problem, though, is that if you map, as you all know, if you map very small areas, and particularly if they're very small populations, these can vary enormously just by random chance. And so we needed, the third thing that was really needed in order to do the sorts of maps that we're able to do now is modelling, complex statistical modelling that allows you to smooth out those differences, those random fluctuations between neighbouring areas in order to see the underlying patterns. And that, of course, is Bayesian statistical mapping. So with Bayesian mapping, you can smooth out areas very easily, and we can include areas in a map with very small numbers of people and still have reliable estimates. Bayesian mapping, of course, is not new. I know many of the audience uses it, and one of the earliest Bayesian maps was in 1993. So why did it take so long for us to develop it to the point where we're at now? And the answer, of course, is computing power. You need very large, easily accessible, powerful and fast computers and the appropriate software to do this sort of mapping. We now have that as I'm sure in Canada and the USA, but we're only a small charity, relatively small charity in Queensland, and we now have access to this cheap, fast, big computing power that enabled us to do this mapping. Not only to do the mapping, but to do visualisation in a way that would not have been thought of, I think, even 10 years ago. We worked with a very skilled team of visualisation experts and IT experts, and the key thing that we wanted to achieve was to make this map intuitive. We wanted it to be used by school children, by their teachers, by scientists, by clinicians, by government, by policymakers. So we needed to make it able to be drilled down to different levels of detail and complexity depending on what you needed. So we spent a lot of time with community members, stakeholders in focus groups and workshops, just running things past people. Do you know what this means? If we put this on a map, do you know what this means? What do you think this means? I don't know whether you'll agree that we got to the point where we have made it intuitive. I hope you will when I show it to you. But one of the main things that we found very difficult to understand how to communicate to people visually on a map without someone explaining it was the concept of uncertainty. These are Bayesian estimates that we're mapping, not the actual data, and they have a range around them, a confidence interval or a range of uncertainty. How do you communicate that on a map to someone to whom this would be a new concept? I'm not going to spend time today going through exactly how we do that. There are a number of ways we use in the atlas. This is one of them. On your bottom right is a V-plot, where each one of those dots represents one of those 2,147 areas around Australia. So if you pick your suburb and put that into the map, your suburb will be highlighted on such a V-plot, and you can see the probability that that's likely to be truly different from the Australian average, and whether that's blue or whether that's red. So we hope that we've been able to achieve that understanding, or at least help the general community to understand this concept of uncertainty. I'm coming to the end now of the lecture part, and then I'll get on to the demonstration part, but I'd like to acknowledge the people that have, and the organisations that have helped with the map: the Cancer Council Queensland, universities, Government Cooperative Research Centre in Spatial Information, the Australian Government, a number of centres of research excellence, and a great number of people, led by our two star statisticians, Bayesian statisticians Peter Barty and Kerry Mengerson, epidemiologists, visualisation experts, project managers, IT experts, and a project advisory group led by Professor David Roeder, who is here today, not in this room today. I'm sure he's enjoying a talk somewhere else today because he knows all about this one already. But it was a very big team that did this atlas. So the proof is in the pudding. Shall I move over now to the laptop? Melanoma is a cancer that is associated with Australia for good reason. We have the highest rate in the world, and this state of Queensland in particular, can you see the pointer? My home state has the highest rate of melanoma of any region in the world. So now let's have a look at the distribution of the diagnosis of melanoma in Australia, keeping in mind red is high and blue is low. So you can see that the vast majority of cases are diagnosed around this part of Queensland. Melanoma is by no means distributed evenly across the state. And in fact, we have some blue areas here where it's very low incidence of melanoma, and certainly in the interior, we have a large proportion of our Indigenous population living in the state, in the Northern Territory here, and of course melanoma rates are much lower in that population. I'm now going to switch to a different cancer which has a completely different risk factor profile and socioeconomic profile, and that is liver cancer. And you can see how, sadly, how common liver cancer is in Central Australia and Northern Australia, in large part because of untreated hepatitis infection, which is prevalent in our Indigenous community. It's also low socioeconomic area, high alcohol consumption and other high lifestyle risk factors which increase the risk of liver cancer. But if you look down on the far bottom left-hand corner, this box represents our capital cities. Each of those bars is a capital city. The first one on the top is Sydney, so let's just concentrate on that. Because the SA2 little tiny areas are so tiny within the cities, there are hundreds of them, you can't see them on the map, and so this is a way of showing you that there are a proportion of those little SA2 areas in Sydney, for example, that also have very high rate of liver cancer. So I'm just going to type in a suburb of Sydney. And the map will now take us down to Sydney. You can see the suburbs. I'm just going to go back a little bit. And there's an area of Sydney which is an area where immigrants coming from areas of the world with high hepatitis rates have settled, and we have very high liver cancer rates like that in patches in every one of our cities. You would think that this information would have been known, but it has opened our eyes to areas of the country where we need to concentrate, and we really need to focus our cancer control efforts for particular cancers in particular areas. Education, obviously, and vaccination and treatment of hepatitis. So many things we can now do that we sort of knew in the background, but it wasn't as clear as days. as it is from this map. I'm going to go to melanoma again. One of the reasons that the rates are so high around this area is because this population around Brisbane has been told for decades that we have the highest rate in the world, and we all rush off and have our skins checked every 12 months. There are now a plethora of skin cancer clinics all around this area. On every street, you'll see a skin cancer clinic almost. It's fantastic because it means early diagnosis. But the thing that is beginning to become clearer and clearer is the overdiagnosis of disease, of cancer, in high SES areas who are very aware of screening. And I only need to mention PSA screening to have everybody nodding now and understanding what I'm talking about. And that is what is happening with melanoma. In some part. Now, of course, some of the early diagnosis is not just overdiagnosis, it's really early diagnosis of cancer that would otherwise have killed the patient. So what we'd like to see is, if we look at deaths, we would like to see that patch being blue. And it's not very blue, but if I blow it up a little bit and you squint, you can actually see there is, compared to the rest of the country, we have lower death rates from melanoma in that same little patch where we have overdiagnosis, some overdiagnosis. I'm going to try now and take us back to another cancer. I'm going to go back to incidence, and I'm going to go down to thyroid. Now there's huge, there's something about the health awareness of the worried well around this area. This is showing that there's and if you look at this little green bar here, this tells us if that bar is all green, it says that there is significant, statistically significant geographic variation in whatever we're looking at, in this case, thyroid cancer. So there is a statistically significantly higher incidence of thyroid cancer around Brisbane, around Sydney, around Melbourne, and around Perth. Again, no doubt some overdiagnosis, but we would hope to see differences in death rate if things are being picked up early. Let's have a look now at thyroid cancer excess deaths. 0. And you can see evidence of variation has disappeared. There is absolutely no evidence of variation in death rates or in excess deaths from thyroid cancer around Australia when there is significant variation in incidence. So this is telling us things about diagnosis of cancer, about effectiveness of diagnosis. I could show you many more things, but I'm going to leave it at that. Quit while I'm ahead. And thank you very much for your attention. And also to remind you, if you want to look at this yourself, it's freely available online. Just type into Google Australian Cancer Atlas or use this link and that will come up. Thank you.
Thank you, Dr. Aiken. Are there questions for Dr. Aiken?
Can you hear this? Yeah,
Yes,
that's
Michelle.
better. Hi, Joanne. Thanks very
Michelle.
much. That was a stunning demonstration of your atlas. Thank you very much indeed. Can I just ask you about overdiagnosis? When you mentioned melanoma in and around the border there by Queensland and New South Wales. By overdiagnosis, do you mean that people are being diagnosed with melanoma who actually don't have it? Or do you mean that people are being diagnosed with melanoma because we've changed the definition by which we establish a diagnosis of melanoma?
Thanks, Michelle. That's a very good question, and I mean the second. I mean diagnosis of melanoma that is today called melanoma, but which has no likelihood of impacting on the patient's longevity. I think both things are happening, but I'm talking about the second. If you look in time, the diagnosis, the criteria that a pathologist uses for diagnosis of severely dysplastic as opposed to in situ melanoma versus invasive melanoma is moving towards the conservative end. In other words, things are now being diagnosed as in situ that perhaps would have been dysplastic nevus in the past.
So this was very exciting and really fantastic. I guess I'm wondering, is there an opportunity to learn from you, to share some of these tools in other countries and apply to our own data? Because this is just marvelous.
Thank you, Lynn, for that question. Yes, resounding yes. We've already worked with the New Zealand government. We've held workshops with the New Zealand government, and we've trained their people, so they're now doing a Cancer Atlas of New Zealand. We're very keen to use this. We've spent a lot of time and money on this, and this is for the population of the world, not just for Australia. So we'd be very keen to do anything.
Thank you. We have some more time. Are there questions for any of our speakers? Okay, seeing none, thank you, and enjoy your lunch. Enjoy the rest of the day.